Hi, my name is Kate Sullivan. I'm representing the Medical Advisory Board of the Immunodeficiency Foundation. Today is May 8th and we are in week 8 of the pandemic for most of the East Coast. And we have learned some lessons along the way, and this update is going to cover a few things really focused on immunology and treatment. The topics I hope to cover today are treatment, a little bit about statistics, which I think is important to help understand why it's not always clear what treatment is working, and then I'll end with vaccines and immunoglobulin. So let's start with treatment, and the treatment I'm going to divide into two sections. The first section will talk about antiviral compounds, and so this is what makes the most strategic sense. If you have a pandemic with a new virus, you want an antiviral drug to help combat it. So why are there so few antiviral drugs compared to antibacterials? The reason is that viruses live inside of our own cells, so it's not easy to poison them without poisoning our own cells. So historically, the development of antiviral compounds has been much more complicated than finding antibacterial compounds for just that reason. So there are 5 antiviral compounds I want to talk about. The first is hydroxychloroquine. That certainly has been in the press more than any other. There was a small study in China and a small study in France that was cause for some optimism, but then a much larger study that was done found that it offered no benefit at all. And I'll explain why these studies are formulated differently and why they might say different things in a minute. But I think hydroxychloroquine certainly at this time has fallen out of favor. In a previous video, I spoke about lopinavir and ritonavir, a drug combination that's often used in HIV. That also has now been studied in quite a large trial and found to be of no benefit. So let's move on to happier news. So you probably heard Tony Fauci on TV talking about a drug called remdesivir. This is a drug originally developed to treat Ebola, where it was not effective, but it was known to work in a test tube for other coronaviruses, and now there have been large tests of its efficacy. The test that Dr. Fauci was talking about on TV showed that remdesivir is of benefit and shortened hospitalization by about 3 days. There is apparently another study that shows remdesivir was not effective. And again, more on statistics and why you might have 2 studies that say different things in a minute. Neither of the large studies have been published yet, but I think the fact that Tony Fauci endorsed one that showed benefit certainly says something. He's a very cautious scientist, and I think he would not have spoken about it without being fairly confident that it worked. That brings me to 2 that are much more untested. So one is favipiravir, which was developed for influenza. It's been studied in about 120 people, so not a very big study at all. It did seem to show some limited benefit. And then there's umifenavir, which was studied in one group of 16 people where it showed a benefit, and it was studied in another group of 35 people where it didn't show any benefit. So let's move on and talk about statistics. It's not the most exciting subject, but I think it's really important to try and understand why studies might show benefit in one setting and not in another. So in this slide, I'm portraying 100 people that are infected with COVID-19, or technically the SARS-CoV-2 virus, but they have the COVID-19 disease. So we think, the data aren't very strong, but we think for all people that are infected with the SARS-CoV-2 virus, we think about 80% are going to feel kind of crummy, but get better at home and not need any additional medical treatment other than maybe something for their fever and aches and pains. About 20% will end up going to the hospital, and of that group, about half are managed in a regular hospital room and about half go to the intensive care unit. So I've portrayed those as green, yellow, and red with increasing severity of disease. And so roughly 80% of folks will get better at home, 20% go to the hospital, and 10% of the whole group end up in the intensive care unit. So you can imagine if someone did a study of 20 patients testing a new drug, those 20 patients are shown in blue here, that maybe if they all got better, They were all going to get better anyway. They just happened to be 20 patients from the largest group that were destined to get better anyway. And this shows why it's so hard to extrapolate from these small studies. Now, when you start collecting 500 people, you get a much better sense of the effectiveness of a drug, because likely you're going to capture people that were destined for severe disease or at least hospitalization. So this is why you can sometimes hear that one study was positive and another study wasn't. I want to talk about the medications that we refer to as immune modulators, but to do that I need to just review what happens with infection. So from the time of infection, it's about a week before people start to feel sick, and then it's another week before you can kind of tell whether someone is going to get better on their own or need hospitalization. And if we look at what's happening to the immune system during this time, you can see there's an initial production of type 1 interferons. These are sort of the early warning system, and their production slows down the spread of virus. They're actually critically important for the immune response, and people who have problems with this particular part of host defense are very susceptible to viruses. Then you'll notice that we go on to make IgM and then shortly thereafter IgG, IgG being the more durable of the two antibodies. And at this time, right around the time people are developing symptoms, there's a large expansion of T cells. Remember, T cells are the soldiers that are actually going to kill the virus, and they expand from about 1 in 100,000 cells that recognize the virus to a very large number of T cells. And then that T cell population shrinks back down. So it's again about 1 in 10,000, maybe as many as 1 in 1,000 of our T cells. So this enormous growth in T cells is to just bring more soldiers to fight off the virus. So this is what happens when someone gets better. What happens when someone gets sick? Well, we think that one of the mechanisms for the folks that are sickest is that this T cell process is maybe slow to kick in, but ultimately it kind of overshoots and there's a lot more T cell activity and the production of inflammatory cytokines. And it's many of these inflammatory cytokines that really get people into trouble. So in this slide, I'm showing some of the consequences of having what you might have heard referred to as cytokine storm. The idea is that you've got all of this inflammation sort of bubbling around and causing a storm. I think it's a really evocative name. But what are the practical manifestations of that? So fluid in the lungs, or you might hear this referred to as acute respiratory distress syndrome, myocarditis or inflammation of the heart, hepatitis, inflammation of the liver, kidney injury, and then the blood vessels themselves can be infected. And this can cause harm in essentially any organ, but it's also led to some of the problems with clotting that you may have heard about. So essentially any organ can be involved. In adults, it's more about lungs. You might have heard that there are some children now being described where their heart is more involved or they have a rash. So it can be a little bit different from person to person and maybe depending on age. But the consequences of these inflammatory cytokines ultimately can impact any organ. So what are some of the immune modulatory treatments that are being brought to bear? Well, they're largely focused on this production of cytokines. So the most old-fashioned treatment is steroids, and the one for which there is the greatest amount of data, which is now being used at least somewhat routinely for the sickest of patients in the US, is a drug called tocilizumab, which blocks IL-6. There are some others that I've listed here for which there are at least some little bits of data to support their use, but notice that the concept here is actually suppressing the immune system. So with this in mind, what happens if an immune deficient patient gets COVID-19? Well, we don't know for sure, and it probably is different for different patients, but there's a group from Italy that reported that 2 men with X-linked A-gamma globulinemia got COVID-19 and did just fine. And then there's an international survey that went out that now has collected over 50 patients, and the rate of hospitalization does not seem to be markedly different for the immune deficient patients compared to the rest of the population, meaning about 20% ended up in the hospital. So it's a mixed group of diagnoses, so we still need more data before we can give specific advice for people with individual diagnoses. I bring up vaccines not because there's any new hard data, but just to set expectations. So think about the vaccines that we have available now. So the tetanus vaccine is hugely effective. Most people that get the tetanus vaccine make antibody and they are fully protected. And then there's a range of vaccines in the middle. So the pneumococcal vaccine is pretty effective, but not entirely protective. And then there's the influenza vaccine, which we give every year because it's better than nothing, but it typically averages about 70% efficacy in terms of preventing infection. And really one of its more important roles is that it prevents severe disease, not necessarily that it prevents any and all infections. Well, why am I bringing this up? It is entirely possible that a vaccine for the SARS-CoV-2 virus to prevent COVID-19 might not be 100% effective. And why do I say this? It turns out that there are a very broad range of coronaviruses. Some of them cause human disease like colds, but some of them cause agricultural disease in pigs and cows and chickens. And those folks have been working to develop a vaccine for their specific species coronaviruses for some time. It's been hard to get a vaccine that achieves 100% effectiveness. So I just want to set expectations that it may not be possible to get a vaccine where we can guarantee there is no virus circulating in the community. It is quite likely that even with a vaccine, there will continue to be little bits of this infection that burble up here and there in different communities. I'm going to end by talking about immunoglobulin products and whether they offer any protection. So you might wonder, if there are lots of coronaviruses circulating in the community, people probably have antibodies to them, and those antibodies are probably in the commercial immunoglobulin products, and you would be 100% correct. Are they protective against the current coronavirus? It's unclear. If there is protection, it's probably quite modest. Generally speaking, you don't get much benefit from cross-reactive antibodies in terms of protection from infection. So I don't have a great answer for you, but even if there was cross-reactive antibodies that bound to the SARS-CoV-2 virus, it's unlikely that there would be much benefit from it. So I hate to end on a negative note, so I'm going to circle back to vaccines. Because of all of the agricultural infections and because of the previous outbreaks of SARS and MERS, we actually know a great deal about what works and what doesn't work for vaccines. And so when you hear people on TV saying, we'll have a vaccine in a year, we'll have a vaccine in a year and a half, it's really resting on the shoulders of all of those previous vaccine efforts. You may remember that the previous vaccine that was brought to market took 28 years. That's the rotavirus vaccine. So it is typical for vaccine development to take decades, not a year. But we are benefiting from previous research done on other coronaviruses, and that's why people think that it is likely that there will be a vaccine on the market within a year to 18 months. And I think that gives everyone some hope. So stay safe and be strong.